So good afternoon, everyone. Hope you all are doing well. Today we are going to present some high yield questions and topics as regards to adrenals. All these questions and topics and themes have appeared in the previous year exams in SCE and the European Board exam. So basically all these series of videos are set to serve as a quick revision of the high yield topics, which will be extremely important before the exams as well. So let's start right away with the adrenal part. All right, so as I mentioned, today we are going to discuss some high yield questions and themes of topics as regards the adrenals, which have appeared in the previous years, extremely important and high yield for the coming exams. So let's start right away. We have question number one. Here we have a 56-year-old woman who has presented with fatigue and headache after receiving 4 doses of ipilimumab. This is a monoclonal antibody which works against the CTLA4 used in the treatment for metastatic melanoma. A detailed blood workup was carried out in view of her symptoms of fatigue and headaches, and that came back as a sodium of 129 millimole per liter, which is low. ATM cortisol was done and it was around 100 nanomole per liter. The usual range between around 275 to 555 nanomole per liter. And the short Sanington test showed 30-minute stimulated cortisol of only 150 nanomole per liter. So here we have signs and symptoms of fatigue and headache and workup showing hyponatremia and a low cortisol and a failed short Sanington test. Let's move on to the question. So based on the above, adrenal insufficiency was diagnosed, which was pretty obvious from the question stem. Now, this is the CT appearance of the adrenals given. This is A before the start of the therapy and B after the start of the therapy. Okay, so let's move on to the next image in the question. MRI pituitary was provided as well, and this is the MRI pituitary image. So what is the likely etiology of this case? So we remember the question stem, adrenal insufficiency, and patient is on ipilimumab. Okay, so what is the likely etiology in this case? Option 1, adrenal hemorrhage. Option 2, adrenal metastasis. Option 3, adrenalitis. Option 4, hypophysitis. And option 5, adrenal infarction. So let's see what is the answer. So the correct answer is adrenalitis, also sometimes referred to as autoimmune adrenalitis. So basically, what is the explanation is that before ipilimumab, we can see the adrenals are of normal size, but after therapy with ipilimumab, we can clearly see a hyperplasia of the adrenal glands in the image B here. So let's look at the explanation. A subsequent surveillance CT scan, the figure B, showed bilateral enlargement of the adrenal glands. The dynamic size change of adrenal glands suggests ipilimumab-related autoimmune adrenalitis. That is the etiology of the adrenal insufficiency in this particular patient. Although the secondary adrenal insufficiency is fairly common endocrinopathy related to ipilimumab, the identification of primary adrenal insufficiency is equally important. What do they mean by that? But basically, if you look at the MRI pituitary, the MRI pituitary was normal in this patient. And the workup in terms of the adrenal insufficiency, it was clearly with a failed short Sanington test with a low random serum cortisol. Now, in general, when we talk about the main differential in this case, so our case was ipilimumab-induced adrenalitis or autoimmune adrenalitis. When we're talking about the main differential in this case, usually, typically, what we call it as hypophysitis. So even these ipilimumab, which we also call it the immune checkpoint inhibitors, they can also cause hypophysitis. So that can also manifest as adrenal insufficiency. Obviously, that will cause secondary adrenal insufficiency, can cause fatigue and headache, but we'll have some other indications in the question stem, like we may have a low level of the pituitary hormones. We may have a low ACTH, we may have a low TSH, FSH-LH may be low, growth hormone prolactin also may be low. And the diagnosis of hypophysitis is also supported, apart from these biochemical tests, radiologically by enhancement and swelling of the pituitary gland. So our pituitary MRI in the question stem provided was totally normal. But what is the appearance which can indicate that hypophysitis is a diagnosis in this case? There will be what we can refer to as hyperplasia of the pituitary gland, which can happen. So as you can see, this is a normal baseline pituitary gland, and here you can see after therapy with ipilimumab, there is enlargement of the pituitary gland. So that is what is shown, that there may be enhancement and swelling or hyperplasia of the pituitary gland. Just like as it can cause adrenal gland hyperplasia, it can also cause pituitary gland hyperplasia. The diagnosis in our question stem is of course adrenalitis, because the other hormones are not provided. Even the MRI appearance was normal. If the MRI appearance of pituitary suggests that there is hyperplasia of the pituitary gland, plus there are other hormonal deficiencies which are shown, like low TSH, low ACTH, low FSH-LH, low growth hormone prolactin, these all will be indicative of hypophysitis as the cause in this case. Now, a very important topic for exams is this checkpoint inhibitors, which we also call as immunotherapy. And Society of Endocrinology has provided guidance in this regards. Now, why it is important? Because it is also associated with these endocrinopathies. Okay, so what are these immunotherapy agents? They also referred to as checkpoint inhibitors. Ipilimumab, which we saw in this question stem, it is a CTLA-4 inhibitor. There is another drug, nivolumab, and there is another very important drug called pembrolizumab. This is basically programmed cell death 1 type inhibitor. This has significantly improved prognosis in number of cancers, and that's why they have been increasingly used. And that's why it's very important to know the endocrinopathies which are associated with these checkpoint inhibitors. Now, immune-mediated endocrinopathies, as a consequence of treatment with checkpoint inhibitors, it includes hypophysitis, which was not our case, but adrenalitis, which was seen in our case, thyroiditis, and diabetes mellitus. So it can also cause thyroiditis, and it can cause also diabetes mellitus. What type of diabetes mellitus? Pembrolizumab, which is a PD-1 inhibitor, can cause pancreatic failure and an insulin deficient diabetes mellitus. Okay, so it produces a picture of type 1 diabetes mellitus. This is extremely important for exam, again asked as a question in the previous exams. So apart from that question, another question which we are seeing in this scenario. What are the other important effects of these checkpoint inhibitors which we should know of? We always should monitor the TSH of these patients. If, of course, the FT4 is within the reference range, but the TSH is high, then we are talking about subclinical hypothyroidism, which is possible. And if the patient is symptomatic and the TSH is more than 10, then in this case, thyroxine will be indicated. If is asymptomatic, then repeat TSH and consider thyroxine if TSH more than 10 2 times. So this is again a very important guidance. This is specific to these checkpoint inhibitors. Okay, so this is guidelines from the Endocrine Society related to the checkpoint inhibitors. So this is the management of subclinical hypothyroidism secondary to the checkpoint inhibitors. TSH more than 10 with symptoms, start treatment. If asymptomatic, we need at least 2 TSH, which is more than 10. Second thing, we are talking about primary hypothyroidism. So in this, again, the TSH is of course above the reference range and the FT4 is below the reference range. In this case, if the patient is symptomatic, directly go for the treatment with thyroxine. If asymptomatic, repeat TSH and consider thyroxine again if TSH is more than 10 on 2 occasions. So this is very important to note for exam. So again, these can appear as question scenarios in the exam. So it's important to note the thyroid problems which can occur with these checkpoint inhibitors. The other thing is that we should also not forget about it as a cause of secondary hypothyroidism. So in this cases, the TSH may be within the reference range and the FT4 may be below the reference range. And in this cases, it's extremely important to check the 9 AM cortisol. Why? Because we always want to treat the cortisol deficiency first before we are thinking about starting thyroxine in such patients. Otherwise, it can precipitate a adrenal crisis. So that's very important to note that it can also cause hypopituitarism. It can also cause hyperthyroidism, these checkpoint inhibitors. How do they cause hyperthyroidism? By the mechanism of thyroiditis. Okay, so usually the hyperthyroidism for checkpoint inhibitors needs only symptomatic treatment like beta blockers. In terms of hypothyroidism, we mentioned thyroxine will be needed based on the signs and symptoms. But hyperthyroidism secondary to thyroiditis will need only symptomatic treatment. Okay, and of course, as I always mention, as I mentioned, that if the TSH is below the reference range and the T4 is also below the reference range, that may indicate hypopituitarism. And in that case, again, we need to check the 9-AM cortisol and then follow with the algorithm to basically this basically needs hydrocortisone before the thyroxine. So very important manifestations of these checkpoint inhibitors and their effect on the thyroid function. So very important now to remember from the first question about the effect on the adrenals, how it can cause adrenalitis, how in terms of the pituitary it can cause hypophysitis. In terms of the thyroid, it can cause hypothyroidism or hyperthyroidism, or it can even cause hypopituitarism, and how the PD-1 inhibitor, pembrolizumab, can cause pancreatic failure and insulin-deficient diabetes mellitus. Extremely important topic for exams, these checkpoint inhibitors and the endocrinopathies which are associated with. Let's move on to question number 2. So we have a 46-year-old woman who has attended the clinic for routine follow-up. She has adrenal Cushing's syndrome. She is diagnosed with adrenal Cushing's syndrome. So routine medication includes metarapone 500 mg 3 times a day, ketoconazole 200 mg once a day, and hydrocortisone 10 mg in the morning and 5 mg in the evening. Metarapone inhibits the action of which enzyme in the steroid pathway. Okay, so basically here we have a patient of adrenal Cushing's syndrome. She is taking metarapone, which is obviously adrenolytic drug, and that's why understandably the patient is also on hydrocortisone to balance the same. She's also taking ketoconazole. Now the question which is asked in the exam is which enzyme in the steroid pathway does metarapone inhibit? So these are the options. So 3-beta HSD, 5-alpha reductase, 11-beta hydroxylase, 17-alpha hydroxylase, or 21 hydroxylase. So let's look at the answer. So the answer is 11-beta hydroxylase. So basically, metarapone inhibits the 11-beta hydroxylase, and of course, then it will inhibit the conversion of 11-deoxycortisol to cortisol. It will also inhibit the conversion of 11-deoxycorticosterone to corticosterone and subsequently to aldosterone. So there will be definitely an adrenolytic effect, and hence it is used in the medical treatment of Cushing's syndrome. So it blocks and inhibits the 11-beta hydroxylase, which catalyzes the conversion of these products, which I mentioned, 11-deoxycortisol to cortisol. It's 2-hour half-life, so it has a short half-life, and that's why we need it more times a day, like 3 times a day, as in this patient. So metarapone, it's important to note that it can cause the gross elevation of circulating levels of cortisol precursor, which is 11-deoxycortisol. So as we can see in this graph, it can cause an increase in the 11-deoxycortisol levels. This may actually cross-react with many immunoassays for serum and urinary cortisol. And that's why it will give us a falsely elevated apparent cortisol values, and it will potentially mask an underlying biochemical hypoadrenalism, which can occur secondary to metarapone. And that's why it's important to measure these with liquid chromatography tandem mass spectrometry. Okay, and that's why it's important to measure the cortisol assays with liquid chromatography tandem mass spectrometry. This is very important. With no cross reactivity, the treatment target is usually the urinary free cortisol should be maintained in the normal range, or the mean serum cortisol levels should be maintained between 150 to 300 nanomole per liter throughout the day. Okay, so again, very important statements. The most important is, of course, the inhibition of which enzyme and what are the products which are elevated and how it can falsely show an elevated cortisol in the various immunoassays, and which immunoassay is the treatment is the assay of choice. So we have the liquid chromatography tandem mass spectrometry. What are the other adverse events which we should also note of metarapone? The most commonest, if we ask, is gastrointestinal disturbances. Okay, so the most common side effect is gastrointestinal disturbance like nausea, vomiting. Again, very important to note that with chronic therapy, hirsutism and acne may worsen due to accumulation of the androgenic precursors. Of course, we can see that this pathway is getting blocked here, so the androgen precursors will be elevated. And if the androgen precursors will be elevated, what is the side effect which we will get? Is we'll get the hirsutism and acne. And this is very important. Okay. Of course, the accumulation of the mineralocorticoid precursors like the deoxycortisol, deoxycorticosterone, this will require monitoring for the electrolytes like potassium, edema, and if there is any hypertension developing secondary to it. Metarapone is the drug of choice of Cushing's syndrome in pregnancy. So another important question which has appeared before in the exams. What else is metarapone drug of choice in? So metarapone is drug of choice of Cushing's syndrome in pregnancy. So again, very important. So this concludes for metarapone, which is a very important topic for the exams. Let's move on to question number 3. So here we have an otherwise healthy 50-year-old Caucasian woman presented to outpatient clinic with blood pressure readings of more than 180 by 100. Plus, she has on and off headaches, palpitations, and episodic muscular pain. She denies any chest pain, shortness of breath. The pressures were in contrast. These pressures were high, definitely, and these were totally in contrast to her normal baseline blood pressures, which was noted over the previous years. She also gives a history of dry hacking cough, for which she has been using some over-the-counter cough syrups. She also uses omeprazole for GERD. The patient reported an active lifestyle, including running up to 30 to 45 minutes a day during the previous 2 years, and presented with a BMI of 24. So doesn't look obese. She is having a high blood pressure. On presentation, these blood pressures were totally normal previously. And let us see what is the biochemical parameters provided. So in the lab workup, we find that the sodium is okay. The potassium is low at 2.9. The serum aldosterone level is low. The plasma and renin activity is also low. 24-hour urinary cortisol was ordered and elevated. Levels of total free cortisol were found around 170. Deoxycorticosterone was also ordered. This was low. And the ACTH was normal. Other parameters which were ordered were the catecholamines, and they were normal as well. Now, based on the above clinical profile of the patient, what is the likely diagnosis? So again, reviewing the history, 50-year-old, blood pressure of more than 180 by 100. Baseline blood pressures were normal previously. And she has a dry hacking cough, taking some cough syrups previously, and active lifestyle, BMI of 24. Presenting with hypokalemia, there is hyporenemic hypoaldosteronism. So both the renin and aldosterone are low, and the urinary cortisol levels are elevated with a low DOC. Okay, so deoxycorticosterone is low with a normal ACTH level. So what is a likely diagnosis in this case? Is it Cushing syndrome? Is it Liddle syndrome? Is it 11 beta HSD2 deficiency? Is it 17 alpha hydroxylase deficiency? Or is it 11 beta hydroxylase deficiency? So let's look at the answer. The correct answer is 11 beta HSD2 deficiency. Now, when we look at the mineralocorticoid excess syndrome, we are looking at different criteria. Either we are looking at high aldosterone or low renin, in which you will have classically, which is what we refer to as primary aldosteronism, also called the Conn syndrome, which can be obviously unilateral, bilateral, familial, or genetic. Then we are talking about this important part, which is low aldosterone, low renin, like our patient in this case. This can occur either due to hypercortisolism, which is Cushing's. It can occur due to licorice toxicity, which is secondary to 11 beta HSD2 inhibition, which is our case actually. Genetic, which can occur at a much earlier age. Again, the same. There is a 11 beta HSD2 deficiency, but this is a genetic cause. There can be a Liddle syndrome, which is a gain of function in the ENaC. There can be congenital adrenal hyperplasia variants, which can be either 11 beta hydroxylase deficiency or 17 alpha hydroxylase deficiency. So our scenario is low renin, low aldosterone. So everything we need to think about in this chart. Okay, either it can be acquired or a genetic cause. If, for example, we had a high renin and a high aldosterone, then we are talking about other causes like renal artery stenosis or reninoma, and coarctation of aorta for that matter. Again, if the patient is normotensive, this patient was hypertensive with again high renin and a high aldosterone, then we are talking about Bartter syndrome and Gitelman syndrome. Okay, so again, very important chart summarizing all the important aspects of a mineralocorticoid excess syndrome. Our patient's diagnosis was, of course, 11 beta HST2 deficiency. So we'll look at some more. So basically, how come the 11 beta HST2 deficiency in our patient? As we can see, that this patient was having a dry hacking cough for which she has been using some over-the-counter cough syrups, and many of these contain licorice. Okay, and that's why it can cause a licorice toxicity, thereby causing an acquired inhibition of the 11 beta HST2. Let's look at the differential diagnosis of an ACTH dependent mineralocorticoid excess. It can be either syndrome of apparent mineralocorticoid excess, like our case, in which we'll have low renin, a low aldosterone. We'll have a high cortisol, so high urinary cortisol in this patient. The cortisons will be low, so there will be high cortisol to cortisone ratio. There will be normal androgens. This can be mimicked by licorice ingestion, or it can be genetic, which is autosomal recessive. Again, the defective gene here will be 11 beta 2 HST. Okay, HST 11 beta 2. Now, when we talk about the variants of congenital adrenal hyperplasia, which are also causes of ACTH dependent mineralocorticoid excess, we are talking about 11 beta hydroxylase deficiency and 17 hydroxylase deficiency. Again, in 11 beta hydroxylase deficiency and 17 alpha hydroxylase deficiency, we'll have hypertension.